BCMA is the 5, technically 6 rights of medication administration. That you have to pull back from way back in nursing school. I know you guys already have experience, and this is a refresher. But real quick, can anyone tell me that? Tell me the first right, or one of them.
Time.
Huh?
Time.
Right time, perfect.
Right patient.
Right patient.
Dose.
Right dose.
Right medication.
Right medication.
Right route.
Right route.
Education, signs and symptoms.
Signs and symptoms. Yeah, that's a good
I'm
one.
thinking of the 6th right. I know.
Documentation. Okay, there's a lot more rights now, but those 6 right there. Right patient, right medication, right dose, right route, right time, right documentation. Okay? That is the foundation of BCMA. From the very get-go, when we jump into BCMA, you will see all those start. So I'm going to go ahead and flip to the screen. And on the screen here, underneath our icon, it's the same in every desktop. Let's let those icons load real quick. You will see BCMA pop up right here. Now this is where the live is. This is where you as nurses will go, double click that icon, and you will click on that very first image of the BCMA one right here where my cursor is, BCMA South Texas, okay? The one that has the exact same icon right next to that, that's the parameter file which you guys don't have access to. Now we're not going to go there today, right this second, because we have to go to the test site. We don't want to be messing with actual patients. So we're going to go to the test site. But that's where you would go to do your medications. Give this a second here. All right, so the first thing that it's gonna pop up with is your electronic signature code. A lot of sites and other VAs have disabled this. We've always kept it open, but this is basically your electronic signature code that you use to sign your notes with, okay? Does anyone have any questions on that? You guys have that? Awesome. If not, I can help with that. All right, so the very first thing that pops up is what? Scan the patient wristband. Why are we going to scan a wristband? Why don't we just enter in a social or an MRN number or something like that? Safety, right? You're getting along the line. Safety. We're trying to reduce medication errors on wrong patients. So we ask you to scan the band because we want to prevent errors, right? Plus it's easier. It's easier to grab a scanner and just scan a band that already has it there. It's beep, you're done, right? So here I'm going to grab out my test patient. If my cart will turn on. So my cart's unlocked. I'm going to grab out my wristband. Okay. For those of you who've never seen our wristbands, let me actually grab both of them real quick, just so I can also show people here. So our wristbands are pretty awesome. Has the ability to put a picture. You have your barcode, tells you where they're located, and you can also add a couple different flags about the patient, okay? Has anyone not seen our wristbands here? Perfect. So I'm going to use my test patient here. His name is Twill. So I say he's twilling. He's got a picture over here on a raft with his sunglasses chilling right now. And we're going to scan his band. When I scan, it's going to pop up and BCMA says, well, I don't trust you. I want you to verify this again. So it's going to pull up the full name, social, date of birth, their current ward, location, and the allergies, adverse drug reactions, or patient flags. Our policy here, pretty much to identify a patient, is 2 out of the 3, the full name, the full social, and the full date of birth. With BCMA, our medication policy says flat out, the only 2 acceptable forms of ID is full name and full social, okay? And the keyword of full goes before that on purpose because a lot of people, if you ask for their name or if you state name, a lot of people just say Mike, or Joe or Bob. No one gives their full name, initials, the whole deal. Same thing with social. Everyone assumes last four since we use social here, okay? So, and that was a tidbit that was given to me by our Joint Commission mock surveyist individual who asked my nurse that question back when I was in management, and he said, make sure you're saying full. So I always emphasize that. So, once you have validated all this information is correct, including the ward and the room bed, if you're on the 4th floor and this guy shows he's on the 6th floor, we got a problem. Now, will it stop you from giving medications? No. But could it cause an issue later on? Yes. We're patient advocates as nurses, right? We want to try to prevent safety. While yes, you could continue giving your meds, just don't forget to get with your ward clerk and say, hey, something's not right with the location with this guy, okay? And they can fix it just in case he goes to surgery or some outpatient procedure or something. They don't send him to the wrong floor. All right, so you click yes, and you're ready to go. This is your virtual do list. You'll notice in the top left corner, it brings in the full information, the full name, full social, full date of birth, everything. Right patient, right? Over here to the right side of things, and that section over here to the right, so here's your right patient information. Over here to the right, this is all ways to filter down your do list, okay? So you can filter by order mode, start time and end time, and schedule types. So normally, BCMA was in basically inpatient units. We never really saw it in outpatient areas, okay? So this was never really that big of a deal, but now we've actually put it in a lot of different outpatient areas, and a lot of inpatient areas now have clinics within them for short stays and things like that. So you might have a patient, depending on where you go, depending on what kind of patient they're listed as, like for instance on 2S, if they're in their short stay clinic, but yet you're on 2S, which is normally a surgical area, you might have a patient that has clinic orders. Now this one doesn't, so I click it and there's nothing to show there, okay? But the green dot usually symbolizes that, hey, there's something in there, go ahead and check it out. Now you can also do it to time. You'll notice that it kind of defaulted from 8 to 10, and it's because we're right around 9. So it usually defaults to an hour before, hour after, and that's because our policy says you have an hour before to an hour after to give meds for that right time. Okay, we do that because we understand as nurses, you can't have 5 or 6 plus patients. Back in the day when we used to have teams of 12, you can't give all of your patients all your meds at 9 a.m. So we give you an hour before, hour after. And I recommend, as I tell most nurses, make sure you start that hour before. You never know what's going to happen when you walk into that room the first time. So, schedule types. Continuous PRN on-call one time. The only ones that I actually have listed down here, obviously, is the continuous and the PRN. It's got the green dots. On-call, obviously, to OR, one time for one-time doses. If you uncheck it, it will not show those. So if I uncheck the continuous, you'll notice that the only thing I see is my PRN. Right? If I uncheck my PRN, only that goes missing. Everything else is still there. Be careful that you don't accidentally uncheck more than what you should so that you see this. This actually happened to me when I worked night shift one night. I do not know how I didn't catch it, but when I was doing my meds at midnight, I was pretty excited. I saw this and I thought I had the best patient in the world, no meds to give. I was like, sweet. And then 6 a.m. my charge nurse walks in the door and says, hey, she prints the missing med report and says, why didn't you give your meds on this guy? And then I was freaking out. So I always tell people, be careful when you start filtering things down. So, yeah. All right, so down here is your virtual do list, okay? The first column is status. For status, it's simple. The goal of BCMA is to give medications. So the first status is G for given. And you will see that populate along the sides when we actually start doing some things, okay? But you'll see G for given. You can also have H for held, M for missing dose, and R for refused, okay? The goal, obviously, of BCMA is by the end of your shift, if you change your start time and your stop time to when you begin your shift to when you end, is to see nothing but G's down the line. That's when you know everything's been done, okay? VER, verification. Verification simple. Obviously, here we're familiar with CPRS. Other individuals may not be, but they'll hopefully see it. In CPRS, the doctor writes the order. It becomes pending. BCMA will never show a pending order in here. BCMA doesn't care about pending orders, okay? Once the doctor puts that order in, it goes to pharmacy. You're gonna have to wait a little bit of time because pharmacy has a list of orders that they have to activate, but it goes to pharmacy to get activated. Now, pharmacy does not get a nice little right-click, verify, right-click, chart review, right-click, activate, or anything like that. They work in Vista, which is like DOS, as you guys know. And it is a step-by-step process to activate medications. So it's not that simple. I know a lot of nurses get excited. They're like, oh my God, I have a medication due now. They call pharmacy and they want it now, 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 now. It's not gonna happen that way, okay? So pharmacy looks at that order, and the first thing the pharmacy does is they say, okay, well great, this doctor wants this medication. Did he order it within a normal range of that medication being given, okay? If he did, great. It's within that milligrams that a normal patient could see, right? It's not something way outside the bounds, right? Great. Do we have it in stock? Do we have it in the dosage that they want? If not, we have to rebuild that order. For some of you who are familiar with CPRS, you'll see sometimes a doctor write an order for like let's say a pill for 1,000 milligrams, and then all of a sudden it's DC edited and it comes in at 500 milligrams. And that's because pharmacy didn't have a 1,000 milligram pill, they had a 500, and they had to tell the system behind the scenes it took 2 of those in order to make that order correct, to fulfill that order, okay? Does that make sense? Perfect. Once pharmacy's excited with all that and they're happy, then they activate it. Now it will show in CPRS that it's active, and in BCMA, if you're an NA patient, you can hit the F5 key. F5 will refresh it and bring it in, okay? But now you will see a new medication and it'll have the asterisk on the verification, okay? The asterisk means that a nurse has not verified the order. Why would we want a nurse to verify the order? Make sure it's correct, right? So the doctors who never make mistakes, the pharmacy who never makes mistakes, why do we need the nurse to make sure there's no mistake?
We're all human.
We're all human, exactly. We are the last line of defense, right? Not only that, but I'm a nurse, you're a nurse. I want to be able to look at that order and say, do I agree with that order? Because I'm the one who's about to go give it. Does that not make sense? Okay. So, obviously here I have a lot of them that I have not verified. Some of them I have. Those are my initials. Now, you as a nurse do not have to verify every single time you're going to give a med. It's just when that order is first written, okay? A nurse has to verify it. So if you, hopefully the previous nurse has verified all the orders, but if you get an order on your shift, you will have to verify it, okay? HSM, home self-meds, we haven't really done that here. Most providers here, even if it's a non-VA med, will order them and we'll just provide it to the patient, scan them, and give it to them. If not, they'll put text. If it's something we do not scan or we have, obviously in our system, they'll put something in there as an order that says the patient can take this medication. Obviously, that's a rarity, so we usually don't look at that column. Type refers to these initials, the P, the C, abbreviations, whatever, are the same as what's on your schedule types up here, where it underlines for C continuous, underline the P for PRN, N for on call, and T for one time. The alert, down over here on the right side, you'll see your alert legend. High risk, high alert, and requires removal. So the requires removal is obviously going to be like a patch or something. I don't have a patch on my test patient, but I do have insulin just to kind of show you that caution symbol there. Whenever you see that, whenever you give that medication, it's going to ask for a second verifier. A nurse actually has to go to the computer you're at. They will have to enter in their access code and verify code, okay? Because they need to verify that medication. So for instance, insulin, they're gonna have to look at the vial. Is it expired, right? Is it the right kind of insulin? When they drew it up in the insulin syringe, is it the right amount based off of what you're showing them before they verify that, okay? We used to allow, before they instituted that, just being able to add a comment that was like, oh, verify with Nurse Jane Doe. The problem we found out was that Nurse Jane Doe worked 24/7, 7 days a week, 365 days a year. So now we ask for access and verify codes for many years now. All right, next thing, active medication. So here's another right medication. I'm just gonna go down the column. So right medication, right dosage, right route. Next dose is technically the right time, last action, and last site. These are more of information for you. And these last two columns, whenever you do something, do not always update right away. If you need to force an update, always hit F5 if you have a question. It'll bring all that information back in, okay? And we'll scan some things just to kind of show you that. So, write medication. I'm going to ask this as a simple question. Most nurses should know this. Is the medication dosage always the same as the dosage you're going to give? I kind of already answered this earlier. No. The reason why I bring that up, the example was that 1,000 milligram pill, right? Doctor wants 1,000 milligrams. We don't have a 1,000 milligram pill. We're going to give a 500, but we're going to give a dosage of 1,000, so we got to give 2. That's one of the biggest medication errors that I see whenever there's a medication error when they call me and they say, hey, Mike, can you look in the system to see was this a systems error or a nursing error? Okay, obviously in this one it's a nursing error. So, like, here we go. Here's the perfect one right here. This is a 250, and you got to get 500. BCMA will pop up whenever you go to scan it and ask you to scan both pills. If, and I say this as an if because we are human, same thing with pharmacy, right? I bring this up because this did happen. If it doesn't ask you to scan both pills, you call pharmacy. Now, as a nurse, when you're giving your medications, using BCMA as a tool, right? It's not going to do your job for you. I keep asking it, just like Alexa to wash my car. I keep asking it, BCMA, can you pass my meds? And it hasn't done it yet for me. It requires a nurse, okay, in order to use it, because it still requires critical thinking. So if it's not doing what you expect it to do, call pharmacy. That's all I ask. Pharmacy normally is the one who sets the parameters, and they'll see it instantly. Okay. Any questions on this page so far? We have dosage, route, next dose. Also look at your route. It's like literally on your screen, maybe a couple inches away. And I ask that because we have had in the past times where, I'll give you an example, was we had some eardrops, right? The order said otic, otic, however you want to pronounce it, and it ended up in the eye. And they asked me, Mike, whoa, what's up with the system? Can we change that? And I looked at it, I was like, you want us? I said, you want us to change every otic, otic suspension or drop that's in our system pharmacy file to do that? And that's something that's done by National, right? We can't just change that because every time they do an update, we'd have to change it. And they do it all the time. They update our files. But I looked over here to the route side of things, and the route, and these nice big bold letters, was both ears. And it was very clear. It's just they didn't pay attention to it. So a lot of times the information's on the screen, you just got to make sure you're looking at it, okay? Some nurses get in a rush, and I'll explain that. All right, next one, IV piggyback. So, IV piggybacks, love them. Obviously these are late, but for those of you who can read that, I usually have this blown up 125. I thought I had it at 125%, but I guess I didn't. How many parts are to this order? 2. Perfect. So in this order here, you have your cefazolin and you have your D5, okay, in 50 mLs. Everything has to match whenever you get your medication, okay? So I'm going to go ahead and switch it to the webcam because I do have some examples here of piggybacks. All right. So here's our example of the piggybacks. We also have a foil one that's out. I just haven't been able to procure one yet from pharmacy, where you actually break it in sections, mix it up, and then you hang it, okay? Is everyone familiar with the piggyback, right? Perfect. So both parts have to be correct. The additive and the solution have to be correct. You have to remember, we're giving medications to patients, and medications ultimately can cause an issue with your patient, right? All the way to the worst case possible scenario of death, right? We're not handing out M&Ms, but obviously here, even handing patients M&Ms could have a negative effect, right? In San Antonio especially. So, here's your piggybacks. Let me ask you a question. Which piggyback as a nurse would you prefer to give? Okay, hold on. This one right here,
No.
the pre-mixed, or this one here?
Yeah.
This one. Why do you prefer this one?
You gotta mix it yourself.
You gotta mix it yourself. I love it.
Given.
You know exactly what you're giving. I love it. A lot of individuals get used to pharmacy. Pharmacy, whenever they activate that order, especially for piggybacks, it also asks how many labels they want to print. So pharmacy will actually print out these labels, and it's awesome because our system actually generates a serial number on here that's specific to that patient, that order. The bad news is, and I'm sure a lot of nurses here have seen this as well, anytime anything changes in the background, whether they change the time, they look at it, they modify it, all those serials get wiped and all new ones get generated. So here you are as a nurse, and they've already sent up 3 of these. You grab one off your shift, you go to scan, and it says not found. So then you're calling pharmacy, and they're like, oh, we got to send new labels. Yeah, so. But the other thing is I can technically take this label off, and I can slap it on anything I want to slap it and scan it. It's not the same thing. So you always, as a nurse, anything you can verify, make sure you're verifying, okay? Make sure you're verifying. That's why I like these. Even though they give me a sticky, I can turn it over and see my solution. I know my additive. I get to break it. I get to mix it. I know exactly what I'm giving for safety for that patient, okay? Make sure you're looking at that. All right. IVs. Normal saline. Ignore the morphine right now. That's something we were testing before all this happened, and we were supposed to get together, and it didn't happen. So, right here, normal saline, 100 mLs an hour. It's currently stopped. Okay? Nothing different there. You're going to scan your bag. We're actually going to show you that. But there is a different tab for IV. Is there any questions on the layout of BCMA so far? No? Perfect. All right. Let's actually get into doing what we're going to do. So, let's go ahead and let's give some medications. So I'm going to pretend. So here, let me switch my cam, okay? So here, I have my patient band on, right? I'm in my room, I'm a patient. Normally I would have you guys come up here do this and actually play with scanning. Unfortunately, with current restrictions, we're not gonna have that happen, okay? Unfortunately. So you're a nurse, you're on the floor, right? You're zooming around your floor, right? You're gonna go give your patient some meds, and you're happy, you're smiling, right? Because you're trying to project positive, right? Positive feelings to your patient.
They can't tell I have a mask on.
You can't tell, yeah, I know right now. Everyone's got a mask on, right? Like, can you see my smile?
Right.
You might see the cheeks go up, but anyway, right? So anyway, you go to your room. What do you do? Introduce yourself, right? Everyone always says that, and that's true because we're dealing with medications, but I also want to step you back and let's go to basic nursing. Whenever you go to your room, right, you have your cart, you pull it in front of your room. Make sure you gel, right? Knock on your door still, right? None of those basic things come out. And the reason why I say that is because as a manager, what I used to see was that nurses towards the end of their shift who were happy, right? That's when you really see them smiling, right? Towards the end of their shift, man, they got like a bounce in their step, right? And they're coming over, they're gelling, knocking on the door. Hello, sir, ma'am, right? How are you doing? Just checking before I leave, right? The whole deal, right? But during the day, oh my God, like they're in and out of that room without gelling, no PPE. They got their wound care kits, they got their meds in their hands, they don't even care. All that still is important, especially right now. So I just want to make sure that you bring that back. Even though this is medications, that basic doesn't go away. That's why I always bring that back in there, okay? So, it's simple. I'm going to scan my band, right? You're going to verify with the patient, right? Let me ask you this. Do you walk in and say, hey, Mr. Jones, how's it going? No. Exactly. You're going to ask the patient for their name. You're going to verify it that way. On the inside, you're going to verify their social, okay? And then you're going to scan, right? That simple. Let me switch to my actual screen. So now that you've scanned the band, you're going to verify this information. You're going to click, sure, that's him. Now we have to give some medications. Now, obviously, these are late because I did an hour before to an hour after. They were due at 8, so technically 9 o'clock, so these are really late. And BCMA will show you the late medications for that day, and they won't go away until an action's done because an action should have been done, okay? So, let's go ahead and let's scan. So I'm going to scan my DocuSafe. Senna. And afterwards, if someone wants it, you can take it. No, I'm kidding. So I'm going to scan, and the first thing that pops up is it's 88 minutes after the scheduled time. So right time. So this is part of that right documentation. We're giving a medication late, and now we need to document why. So in this box, give me something. Give me a good, valid reason why you would have a late medication. Patient is an X-ray. Awesome. So patient off floor to X-ray, right? Perfect. You press OK, and then now, pray it doesn't take this long. Usually doesn't. Now we have our G. Okay, G given. First one's done. Perfect, right? All right. Let's go over another one. If you're not going to give, okay, so what I always say is that when you're giving, you're scanning. That is the goal, right? You're just going to scan. If you're not giving, you're going to be right-clicking, okay, or clicking your mouse. So you're either going to click the do list or you're going to right-click your medication. It's the same menu, okay? So let's go ahead and let's go to the Lisinopril, okay? So let's say their blood pressure is out of range. So now we're going to hold it. Okay? Now as a nurse, do you have the ability just to go, I'm just going to hold this? No! You don't, right? Hopefully the doctors put some parameters there, a protocol in your area, right? We don't like to say protocols, but hopefully you have some kind of standing order, right, that allows you to do that. But if not, you're going to call, you're going to call the provider, right? You're going to say, hey, here's the situation, here's the vitals, what do you want to do? They'll give you some instructions. Let's say he says to hold it. So you're going to right click it, and you're going to go down to mark, okay? And we're going to go held. Now this order is not nurse verified. Any order that's not nurse verified and has those asterisks off to your left hand side over here, any action we try and do, whether it's given, held, refused, missing dose, anything, it's going to pop up with this box that says, hey, are you sure you want to continue because it's not nurse order verified? Okay? You shouldn't see that on your floor because most orders are going to be verified. Okay? If not, you can verify it. But I put this in here just so you can see it. We don't prevent you from giving medications. Some sites, I think, have disabled that to where you can't give any medications until you've done it. But again, BCMA is a tool to give meds, and it doesn't account for every situation in the world you're ever going to encounter, right? So we leave it with some leeway. So it pops up with a standard set of reasons why. All right, I'm not a fan of any of these except for one, okay? Even though all these might describe something or some situation, what I like to do is go straight to provider order because the only way you would hold it is with a provider order, right? Or something that says it. And then now you see the H, but you're not done. This is where you're able to actually like document. Right click it again. Now that you actually have an action, you can add a comment. So again, it's going to bring up information about it. It's 91 minutes late. It was held. What kind of comment? So you've just held the medication. You've called the provider. What kind of information do you think we'd probably put in that box?
Another question, the reason. You can put the reason back as it was, a low or out of line.
How is the low BP for MD or to
Okay, perfect. Let's do that. So low BP per MD, hold medication. I usually would put like per MD.
whatever?
Yeah, let's just put Johnson or whatever. Can't type today, it's all good. And then you have your documentation for that. Does that make sense? Awesome. Let's go with the refused. My good old buddy over here, I love to refuse. Lactulose. Because a lot of patients, a lot of chuckles in the crowd. Yes, a lot of people who work med surg. No. not your patient's most wanted item. I did have one patient, not lying, who actually followed me around in the morning one time because he wanted it ASAP because he was going to use it on his pancakes because it's real sweet. Seriously, I'm not lying to you. I was like, all right, well, you'll be my next patient. So let's go ahead and let's actually wait. We're not going to scan. We're gonna refuse this. So again, we right click if we're not going to scan. We're going to go to mark and we're going to go to refused. Again, it's not nurse order verified. We press OK. And it comes up with some canned responses. Again, I am not a fan of these because diarrhea, emesis, nausea is not really a reason for a patient to refuse it. I mean, it may be the reason to refuse it, but usually a provider is going to have something, a protocol that prevents that. If a patient's technically refusing, it's going to be patient request in my mind, right? So I'm going to select patient request. And then I'm going to right click, it has the R now, I'm going to right click add a comment. Okay, now if a patient's refusing something, what do you think you should do as a nurse, right? Do you walk up there and you say, here's your meds, and then the patient says, I don't want them, you're like, sweet, and you turn around, walk out, right? You're thinking to yourself, woohoo, 5 more minutes on TikTok, Snapchat, Instagram, right? A couple more swipes to the left or right, anything like that?
Yeah.
Yep, no, that's not what we do as nurses. Again, nurses are educators, right? We are going to educate our patient. Patient says, I don't want it, we're gonna try to intervene. Sir, ma'am, this is on your care plan. This is why you need this medication. If they obviously still insist they do not want it, what are you going to do now?
Vet refuse.
You are going to call the provider and you're gonna say, hey, huh?
You gonna call the provider?
Oh yeah, you're gonna call the provider because the provider's going to need to know they're refusing it because they have this on, especially this. I mean, usually if they're ordering this, it's not because the patient just loves the stuff and it's an extra little drink for them. They're ordering it because the patient needs it, right? Some patients, encephalopathy, things like that, right? So the doctor has written this order and is expecting a response. If every nurse is just going, refused, walking away and not saying anything, the providers are thinking everyone's having a great day. Now, hopefully they're checking their notes and their orders to see what's going on. But you don't want to catch them 3 days later and they're like, why is this patient still confused, out of it, combative? Oh, wait, nurses haven't been given this, right? So you call and you say, hey, Mr. So-and-so doesn't want to take this. He's refusing. Can you please come talk to this individual? And then hopefully you're right. They'll write something else.
I would just handle that situation just to, vet refuse, do whatever. Strongly encourage educated vet on why, taking the medication, and then, we'll request a substitution. You know what I'm saying? I just always thought it was like it's the patient's right to refuse something.
No, it is the patient's right to refuse. But you also in documentation want to make sure you're covering yourself. So this is what I would kind of write. Patient stated, I do not want it. Patient was educated. MD notified, stated he would educate or talk to the patient. Right? Because during the interaction, the doctor may find out the reason why he doesn't want it is because of X, Y, and Z. And that's when he could say, oh, well, we have a different medication, right? But in the documentation side of things, this completely removes you guys. Right? Comprehensive. Not only that, but it's charted. Because if something happens to this patient, I hate to say it, you guys know as well as I do, it's not necessarily always just the patient you're dealing with. Who else are you dealing with? The family, right? And I like to use this as an example, okay? My wife's family is Hispanic, okay? I can do this, okay? I do not mean this on anything else. This is how they are, right? Any one of our family that gets into the hospital and it's like everyone's jumping on a plane, they're driving in, right? And then what happens? They bust through that door, and it's like, and they're running. Well, the same thing happens if something happens to their family member. Ethics consults, they want to speak to the docs. I was actually in one of them. And they want to know who, what, when, how, where, why, the whole deal. What I will tell you is I got to sit on one with a family member. It was amazing. as a nurse, I will be honest with you, and I'm gonna have to edit this out of my video, but as a nurse on the floor, I honestly, a lot of times you think doctors don't know what the heck they're doing, okay? But I'll tell you right now, we got an ethics consult on a patient. As one of the managers, I had to attend. And it was like at 3:30, and so I was thinking, like, please let this be done by 4, that's my time to leave. 5:30, let me tell you, almost 6 o'clock. But let me tell you, A game. Those doctors walked in that room, and I was expecting it to be a bloodbath against the docs. What are you doing? Why are you doing? Because I had questions. What are you doing? Why are you doing? But I kid you not. They had notes of every single day, what they did, why they did, how the results came back, why they changed their interventions, what they did with those interventions, what's not working, what is working, and where they're trying to go with their plan of care. My mouth was dropped. I was like, what? It was amazing. It was amazing. I've seen that multiple times. You don't think that they're doing that on their end to cover themselves? They are doing that on their end to cover themselves. I'm telling you right now. Okay, I've seen it multiple times. So you as a nurse want to make sure you're covering yourself and doing everything appropriately. Because if something happens to that patient, we have all documentation at every interaction as you're giving the medication is being refused. Patient doesn't want it. Something happens to that patient, you're good. Because you're right, they have the right to refuse. So now the patient's doing it to themselves. Not that we want them to do that. Yes, but that was awesome.
Do you have one time you can add